picture this scenario, right? You've just had maybe a medical treatment or a major surgery.
All right.
You're back home. The anesthesia is completely worn off, and, well, you're hurting.
Yeah, of course.
And you expected some discomfort, obviously.
Mm-hmm.
But as you're lying there, this thought starts creeping in, like, how do you know if the specific pain you're feeling right now is just a normal part of the healing process?
Right, or a glaring red flag.
Exactly, a red flag that something is severely wrong.
It's an incredibly vulnerable position to be in, honestly, because pain is entirely invisible.
Yeah.
You know, you can't simply take an X-ray of your own living room and definitively prove whether the throbbing in your incision is just a standard biological response or, well, a developing emergency.
Which is exactly why our mission for today's deep dive is to decode those invisible signals. We've got a massive stack of source material today: surgical guidelines, NHS patient leaflets, clinical research trials.
It's a lot of data.
It is. And our goal here is to establish the baseline of normal recovery for you. From there, we're going to pinpoint exactly when you need to sound the alarm.
Because understanding those signals can literally save your recovery or, in severe cases, save your life.
Yeah.
We'll be mapping out the hidden signs of surgical infections, the really counterintuitive ways nerve damage manifests, and the clinical blind spots where chronic pain hides long after the tissue is actually healed.
So establishing that baseline of normal healing is critical because looking at the clinical guidelines, they're very clear that zero pain is not the goal.
No, not at all.
Healing requires a massive biological disruption. I was reading through the physiological response protocols, and it's kind of like, it's less like a resting engine just warming up and more like calling in a major construction crew to fix a ruptured water main.
I love that analogy. It's very accurate.
Right. The mild redness, the localized heat, the swelling that is just the body effectively cordoning off the street, bringing in heavy machinery, and like flooding the area with white blood cells to rebuild the tissue.
Yeah, the disruption itself is the proof that the repair is happening. That inflammatory cascade is completely necessary.
So we shouldn't panic at the first sign of heat.
Exactly. The heat and swelling are just vasodilation. It's just blood vessels expanding to deliver those macrophages and neutrophils to the wound site.
Okay, but how long does that construction work actually last?
Well, the timeline varies dramatically. Acute pain generally peaks in the first 48 hours.
Or 48 hours, right?
But the dull aches persist much longer depending on the specific intervention. Like the guidelines for a LATZ procedure, that's a cervical treatment, they state that cramping pain is entirely normal for anywhere from 2 days up to 4 weeks.
Wait, 4 weeks?
Up to 4 weeks, yeah.
Wow, 4 weeks of cramping requires a lot of patience. But I guess the character of the pain is what matters there, right? It's a dull ache, and it should be gradually improving.
Precisely. It should be on a downward trend.
And that brings up this behavioral trap the sources talk about, which they call the boom or bust cycle, which completely derails that gradual improvement.
Oh, the boom or bust cycle is so common.
Yeah, it's like a patient wakes up having a quote-unquote good day, right? Their pain is low, so they decide to do a bunch of chores or go for a long walk. The boom.
And then the bust hits the very next day.
Right.
They wake up with a massive pain flare-up, profound exhaustion, and their recovery just halts entirely.
Because they overdid it.
Exactly. The biological mechanism is really straightforward. The tissue is still fragile. So by overexerting, they trigger a secondary wave of inflammation.
Oh, I see.
They accumulate lactic acid. They physically stress the newly formed cellular bonds at the incision site. So the guidelines really stress steady, incremental pacing of activities.
You want to avoid constantly re-triggering that inflammatory alarm system.
Exactly.
And managing that baseline pain effectively. It relies heavily on what the sources call multimodal analgesics.
Yes.
Which the logic here is avoiding heavy reliance on strong opioids, right? Because they carry huge risks of dependency and, frankly, severe gastrointestinal side effects.
Nobody wants that on top of recovering from surgery.
Right. So the approach is synergistic. You combine different medications like ibuprofen and paracetamol because they attack pain pathways from two entirely different directions.
That's the beauty of it. Ibuprofen inhibits the COX enzymes locally at the wound site, physically stopping the synthesis of prostaglandins.
And those are the chemicals that cause the swelling, right?
Exactly. Meanwhile, paracetamol crosses the blood-brain barrier and works on the central nervous system.
It raises the overall pain threshold.
Right, so you're simultaneously putting out the localized fire at the tissue level and turning down the master alarm bell in the brain.
That's incredibly effective.
Mhm.
And the clinical data confirms this combination provides exceptional relief for standard acute surgical pain. It lets patients bypass the heavy narcotics entirely.
Yeah, it's a huge shift in how we manage recovery.
Okay, so we've mapped out the normal inflammatory response,
Yeah.
the heat, the swelling, the dull ache, but the guidelines pivot sharply when that expected discomfort changes character.
Yes, they do.
A surgical wound infection completely alters the biological landscape. And what surprised me in the sources is the timeline for when this happens. It's much later than most people assume.
Yeah, the incubation period for harmful bacteria dictates that timeline. A surgical wound infection rarely appears on day one.
Really?
Yeah, it typically develops anywhere from 2 to 3 days post-surgery, stretching all the way up to 2 to 3 weeks later.
Wow, up to 3 weeks.
Sometimes even longer. If metalwork was implanted, such as in orthopedic joint replacements, dormant bacteria can sometimes form a biofilm, and that can trigger an active infection months down the line.
Months. That's wild.
Yeah.
Okay, but visually, how do you know? The visual and physical markers of that shift are highly specific, right?
Yep.
Normal information is contained.
Abnormal redness spreads aggressively. It's typically more than 2 centimeters beyond the wound bed itself.
2 centimeters, got it.
And that mild warmth turns into severe localized heat. But honestly, the most graphic and definitive indicator in the literature is the discharge.
Right, the purulent discharge.
Yeah,
Normal wound exudate is usually clear or maybe slightly blood-tinged.
exactly. But abnormal purulent discharge is thick, opaque, and colored white, yellow, or even brown.
Oh.
And it is always accompanied by a distinctly offensive odor.
Yeah, the sources were very clear about the smell. That texture and odor, it's literal casualties of the microscopic war happening in your tissue.
Yeah, it's necrotic tissue, dead bacteria, and millions of spent white blood cells being expelled.
Okay, so if you're at home and you're observing that spreading redness and the purulent discharge, you're dealing with a localized complication.
Sure.
But the clinical warning signs shift entirely if that localized battle breaches the body's defenses. So at what point does a localized infection become a drop everything and call an ambulance emergency?
That pivot is called sepsis. And that is what turns a complication into a medical emergency.
Sepsis.
Yeah, sepsis occurs when the infection breaks into the bloodstream, triggering an unregulated systemic immune response.
The body basically goes into overdrive.
Exactly. It releases a massive wave of cytokines, causing extreme vasodilation throughout the entire circulatory system. So your blood pressure just plummets, which means the organs are suddenly starved of oxygen.
And the symptoms of that systemic cascade, they have absolutely nothing to do with the wound itself.
Nothing at all.
The sources highlight neurological changes, like confusion, slurred speech, extreme lethargy.
Because the brain isn't getting enough perfusion yet.
You also see severe breathlessness as the lungs struggle, profound muscle pain, or a drastic drop in urine output because the kidneys are failing.
If those systemic signs appear, it is an immediate trip to the emergency department. Do not wait.
Beyond systemic infection, the research also highlights some really critical procedure-specific red flags regarding hidden internal damage,
Oh, definitely.
like following a laparoscopy or the surgical management of a miscarriage, if a patient experiences escalating abdominal pain combined with a fever and vomiting.
That strongly indicates accidental perforation of an internal organ, like the bowel or the bladder, basically leaking contents into the sterile abdominal cavity.
Which is terrifying. And then there's the immobility required during and after major procedures. That presents another massive physical threat.
Yes, deep vein thrombosis, DVT.
Right. The stasis of blood pooling in the lower extremities, combined with the body's hyperactive coagulation state post-surgery, the patient will develop a painful, red-hot, swollen leg. And it's completely disproportionate to the surgery itself.
And the catastrophic risk there is that the clot fragments and travels directly into the pulmonary artery.
Causing a pulmonary embolism. Sudden chest pain, shortness of breath.
Exactly. We are dealing with immense mechanical and biological forces during recovery. Throbbing, spreading heat typically points to infection or tissue complications. But the clinical data reveals a separate category of pain entirely.
Yes.
One that manifests not as an ache or a throb, but as an electric shock.
Right, the hidden wiring of the nervous system. Neuropathic pain. Now, the nature of this is fascinating, but I struggled with the timeline presented in the surgical guidelines.
How so?
Well, if I go in for an operation on my knee, or say a dental implant, why would I wake up with nerve damage in a completely different spot, like the top of my foot or my lip? Aren't surgeons careful? And if the damage happens during the surgery, say a metal retractor compresses a nerve in the arm for 4 hours, shouldn't that be the absolute peak of the agony, the exact moment you wake up?
You would think so, logically.
Why does the research show this neuropathic pain sometimes takes weeks to manifest?
That is because of how the nerve physically degenerates and attempts to repair itself. Peripheral nerve damage during surgery often isn't a sharp laceration from a scalpel slipping.
No.
No, it's usually ischemic damage. As you mentioned, a patient is unconscious under general anesthesia, right? They're unable to shift their weight if a nerve is pinched.
Right. They can't say, hey, my arm is falling asleep.
Exactly. Simply being positioned awkwardly or using tight tourniquets to maintain a bloodless surgical field or retractors holding tissue back, all of this applies prolonged pressure, and this starves the nerve of oxygen.
Okay, so it's an oxygen issue.
Think of the anatomy of a nerve like a complex electrical cable. The inner axons are the copper wires, and the myelin sheath is the outer connective insulation. Pressure damages those inner copper wires without ever severing the outer insulation.
Okay, wait, so the nerve's crushed or starved internally, but structurally it looks totally intact on the outside.
Yes, and that triggers something called Wallerian degeneration.
Wallerian degeneration.
Right. The damaged portion of the axon literally dies back to the nearest healthy point. So immediately after surgery, you don't feel agonizing pain. You feel complete numbness.
Anesthesia.
Exactly. Stage 1. The area is dead to the touch because the signal pathway is just gone. The severe pain only begins when the nerve finally tries to grow back down that empty insulation tube.
Wow, and that volatile rebirth of the nervous system is where the patient's lived experience becomes incredibly difficult because the nerve grows back at an agonizingly slow rate, right?
Ah,
The sources said roughly 2 to 3 millimeters a week.
it's extremely slow.
And as it grows, it misfires wildly. The patient enters stage 2, a phase called hyperesthesia,
Which is a highly unpleasant phase. The signals are completely unregulated.
right, resulting in pronounced pins and needles, violent shooting sensations, or extreme temperature sensitivity. The guidelines note patients develop cold intolerance, where simply walking into an air-conditioned room causes physical agony.
Yeah, the clinical timeline for this recovery requires managing intense expectations. That hyperactive phase can easily last for 2 years.
2 years of shooting pain.
Yeah. Eventually, the nerve matures, the signaling calms down, and the patient reaches stage 3 and 4 hypoesthesia.
Where the extreme sensitivity settles.
Right, the settling pain phase. Though the baseline sensation often remains permanently altered. The final stage is muscle reinnervation, where motor control is restored. But the NHS Trust guidelines are very explicit. This cellular journey takes up to 5 years, and a return to 100% pre-surgical function is never guaranteed.
Never guaranteed. Okay, so we've mapped out pain that lasts for weeks while tissue knits together and nerves that misfire for years as they regrow.
Right.
But that assumes the nerve can heal properly. The clinical reviews reveal a massive, terrifying blind spot in postoperative care.
Yes.
The surgeon inspects the wound. The tissue is perfectly healed. The x-rays are flawless. There is no infection, yet the pain never stops.
You are describing chronic post-surgical pain, or CPSP.
CPST.
Yeah. The clinical definition requires the pain to persist for a minimum of 2 months after surgery.
So long beyond the expected tissue healing time.
Exactly. And specifically after all structural causes like infection have been ruled out.
And the incidence rates for this are staggering. The data shows CPSP affects 20 to 30% of patients undergoing major procedures like thoracotomies, complex breast reconstructions, and limb amputations.
It's shocking, isn't it? Up to a third of these patients are left with persistent, debilitating pain following a technically flawless operation.
Why does that happen if the operation was flawless?
The pathology behind this is central sensitization.
Right.
The peripheral nerve may have healed, but the immense, sustained bombardment of pain signals during the acute recovery phase fundamentally altered the central nervous system.
The brain and spinal cord.
Yes. The synapses in the dorsal horn of the spinal cord undergo a form of neuroplasticity. They become hyperresponsive. They literally lower their threshold for firing, meaning normal, non-painful stimuli like the light touch of clothing are amplified and registered by the brain as severe trauma.
That is awful. And while we often associate this with massive inpatient operations like amputations, one of the most common arenas for chronic nerve pain highlighted in the sources is actually the dentist's chair.
Oh, yes. The dental surprise.
High-volume procedures, right?
Yeah.
Complex root canals, third molar extractions, the placement of dental implants.
Yeah.
They carry a surprisingly high incidence of what is categorized as persistent trigeminal neuropathic pain, or phantom tooth pain.
Because the trigeminal nerve pathway is incredibly dense and highly susceptible to trauma,
From the drill.
whether from the vibration and pressure of the drilling or even just the local anesthetic needle itself.
And what stands out in the dental literature is how frequently this is misdiagnosed.
All the time.
Right. A patient returns complaining of severe, sharp, stabbing pain in their jaw. The dentist takes a panoramic x-ray. The titanium implant is perfectly seated. The extracted socket is filled with healthy bone. There is zero sign of an abscess. To the clinical eye, the site is perfect.
Because dentists are trained to fix structural problems.
Exactly. So they often suspect a hidden microfracture or a problem with an adjacent tooth. They might perform another root canal or pull another tooth, desperately chasing the pain.
But the pain just jumps to the next tooth.
Yes, because the damage isn't in the bone. It's a malfunctioning loop in the somatosensory nervous system.
The structural interventions fail because the target is wrong. The central nervous system is generating the pain independent of the peripheral tissue.
And that structural intervention failure leads directly to a clinical trial in the sources that completely upends the traditional view of surgery as a definitive fix.
This study is fascinating.
Right. If a patient is suffering from chronic nerve pain, say in that trigeminal pathway, the logical next step seems to be undergoing microsurgery to physically repair the nerve.
The phenotypic study of patients undergoing microsurgery to repair the inferior alveolar and lingual nerves presents a highly counterintuitive paradox.
Walk us through it.
So the researchers separated the cohort based on their preoperative state. Group A were those who did not have neuropathic pain prior to the microsurgery, and Group B were those who already suffered from neuropathic pain.
Okay, so for the patients in Group A who went into the operating room without pre-existing neuropathic pain, the microsurgery was remarkably successful.
Very successful. Only 2% developed chronic pain afterward.
But the statistics for the second group are horrifying.
Yeah.
For patients who already had chronic neuropathic pain, going in for a highly precise microsurgery to cure it resulted in 67% of them experiencing the exact same pain or significantly worse pain after the procedure.
A nearly 70% failure rate. The surgical trauma simply piles onto an already hypersensitized neurological pathway.
That's like throwing gasoline on a fire.
Exactly.
Yeah.
The central nervous system remembers the previous trauma, and the scalpel stroke of the new surgery acts as a massive reinforcing signal to those sensitized receptors.
Wow.
Surgery, in the presence of established central sensitization, is often the exact mechanism that permanently cements the pain.
That completely changes how we have to think about treatment. The entire premise of recovery requires abandoning the idea of a neat, linear timeline.
Completely. Pain is incredibly complex. Expected baseline pain, aches and cramps, signaling the biological construction crew at work.
But abnormal pain changes the rules entirely. It burns, it shoots like an electrical misfire, it smells of necrotic tissue, or it triggers systemic organ failure.
And translating those invisible signals, knowing exactly when a boom or bust flare-up becomes a drop-everything emergency that is the core of navigating a safe recovery.
We now understand that conditions like chronic post-surgical pain exist because the nervous system physically rewires itself in response to trauma.
Right, the neural pathways remember the pain. And as the microsurgery data proved, subsequent surgeries often just reinforce that agonizing memory.
Which raises an incredibly provocative question regarding the future of surgical medicine.
What's that?
If the greatest threat to a long-term cure isn't the skill of the surgeon, but the neuroplasticity of the patient's own spinal cord and brain, what if the next massive leap in medical science has nothing to do with sharper scalpels or advanced robotics?
Okay, I see where you're going with this.
What if the frontier is finding a pharmacological way to temporarily switch off the central nervous system's memory-making centers during the entire perioperative window?
That would be revolutionary.
Right. If the brain never biologically registers the trauma of the scalpel in the first place, we might eradicate the phenomenon of chronic post-surgical pain entirely.
It's a fascinating thought.
So, next time you are recovering, pay close attention to those signals. Your nervous system is constantly speaking. You just need the clinical vocabulary to understand it.